It's now my pleasure to call Doug Judy to the stage. And I'm going to take a moment of personal privilege to let you know that Doug has been a really important person in Purpose-Built's journey. He's really been our mentor on all things connected between health and community development. In fact, I remember the very first time when I talked to Doug, Ian Galloway had said, you ought to talk to Doug Judy. He can help you understand this stuff. And I called Doug and I asked him, what were the early indicators to know whether a child or a community is on track for a great health outcome? And he said, oh, that's easy, third grade reading rates. And I almost fell off my chair because that's what we were focused on for great academic and great economic outcomes as well. So we see the connection between all these things. And so Doug and his team at Build Healthy Places Network have just been incredible mentors to us. They've helped many of you in the room think about the connection between health and community development, and have also helped to demystify the healthcare system to us so we can figure out how we can partner effectively. And that's really what this next section is going to be about, hearing about a really cool partnership between LISC and a healthcare provider that's going to really, I think, create a model for others to follow. So, Doug, we're delighted you're here.
Great, thank you. Thanks, honey.
That was nice.
All right, we should go ahead and have our two speakers. Kate and Maurice can come on up. We're going to just sit and have a comfortable conversation here. So we'll lay head up. As Carol said, so I'm Executive Director of the Build Healthy Places Network. We're a national organization. We're a small organization based in San Francisco, but we work with community development and health organizations across the country to really bridge the community development and health gap, because too often those working on investing in communities don't fully recognize that what they're doing is creating better health. And that health right now is often not acknowledged, it's too often not measured, and it's almost never paid for. So our goal is to really get that health ROI, that health return on investment, become part of the normal conversation so that we can actually drive more efforts like all the work you're doing here at the different sites around the country. So today, we're going to start a conversation that's actually going to follow in the next panel about an example of some really great innovations in Northwest Ohio, where healthcare is directly partnering with community development to make a difference. So I'm going to introduce our panelists here. So Kate Sommerfeld is now at ProMedica. She's got a long history working at United Way, and has been now, I think, at ProMedica about almost 4 years, right? Yep. Yeah, started out as the Corporate Director of Advocacy and Community Impact, and is now President of the Social Determinants of Health Institute. Keep in mind, she's at a hospital system. She's President of the Social Determinants of Health Institute. She's helping oversee a 10-year, $50 million effort alongside LISC to invest in communities for improving health. Maurice Jones, many of you may know, is CEO of LISC, the Local Initiative Support Corporation, which is one of the largest community development organizations in the country. It's one of the community development banks and investors, investing over $1 billion a year now into low-income neighborhoods. Maurice's history is really fascinating. So he's a lawyer by training, but was Deputy Secretary of HUD under President Obama, and also spent 2 stints in the Virginia Commonwealth state government, Commissioner of Department of Social Services, and more recently was the Secretary of Commerce there. And I think pertinent to this audience, it's an interesting little twist in your story, is Maurice played a really important role in helping manage initially the CDFI fund that some of you may know of, that provides billions of dollars really for the sort of community development investments that we're talking about today. So with that, we're just going to have a conversation and have time for questions, but I'm going to start with you, Maurice. So just backing up and staying at a high level, sort of what led you to community development, and particularly taking on, you've been mostly in government in the past, taking on this project, running one of the largest community development organizations in the country.
Well, good afternoon to everybody, and it's nice to be here, nice to be with Kate. So I think what led me to community development was really my upbringing. I was born and raised in a little small town in Virginia, 1,200 people, by grandparents. And at the time that I was coming up, the overwhelming economy was tobacco farming and small factories. and sawmills. Those were probably the three pillars of the economy there. And I was a tobacco farmer and worked in a sawmill. In fact, it's what inspired me to go to college, by the way.
Right? Has a powerful effect.
Yeah.
I grew up on a farm too. I definitely went to college for that reason.
Anybody who's wondering about what we need, more tobacco farms, and that'll send kids everywhere scrambling to college. But you know, what I saw, my grandfather went to school for 6 years in a barn, and then because of his race, could not go to the local schools. My grandmother, because she lived in town, could walk to the local school, technical school for coloreds. And I was raised with an expectation that one day, when I was a little older, that I would do something good for places like that. And my journey through life has been trying to find opportunities to partner with communities like my hometown. What LISC allows is for me to partner with both urban and rural communities like my hometown, communities where you've got people working hard every day, trying to do the right thing, and because of lots of factors outside of their control, are struggling to transform. And so I would tell you that it's, from my perspective, it's a blessing to be able to do this for a living and have somebody actually pay me to do it, huh? That's not bad, but that's really the start of this seed for me.
That's great. And LISC is unusual in this area because you have how many regional offices, and then you've got the rural
about
LISC?
35 local offices, and then we work in 2,000 rural counties through about 90 other partners.
Yeah, so there's a LISC office somewhere near where all of you are, so it's worth remembering that. So Kate, you've come through United Way, you come to ProMedica. So what brought you to ProMedica? And tell us a little bit about this Institute for Social Determinants that you run.
So I guess similar to Maurice in that being driven by personal belief and background, my parents were foster parents. And so I spent my entire childhood seeing kids come in and out of our home, sometimes for a night, sometimes for a year. And sometimes that ended well, and sometimes it didn't. And I was adopted, so I was the only child that they were able to adopt. And so feel very much, so much is given, much is required. And so in my journey through both personal and career explorations, just really feeling like, how do you give back, and how do we create strong communities, strong families, strong systems that allow both children and families to succeed. So similar to, I think, LISC, ProMedica is really thinking differently. So we are a healthcare system, and so about 10 years ago, we started to really think about the issue of hunger, and hunger as it relates to health. And so we would have patients that would come into our doctor's offices or into our hospitals, and we would prescribe medication. Our physicians, our providers would prescribe medication, and often that medication says, take with food. And yet healthcare never asks, do those patients have the ability to get food? Do they have food? Are they struggling with food access issues? And so this led us to a journey really thinking about how do we, both internally for our own patient populations, but also for our entire community, how do we think differently? What are we focused on for healthcare? You know, the United States spends the most on healthcare of any developed country, and yet we have the poorest outcomes. And so fundamentally, this belief about how do we think differently about healthcare, how do we ask different questions, starting first with hunger, and then thinking about our role around economic development and place-based strategy and workforce, and our partnership with LISC is just that next exciting frontier in thinking about how do we leverage our resources as a hospital system to drive change in community.
Yeah, and this is a remarkable change. I'm a pediatrician. I worked in a low-income community clinic, and I was never trained to ask that question about food. In fact, I wouldn't say it was said exactly, but you didn't want to ask about something you couldn't do anything about. Yeah. And that is finally changing, and really fundamentally. And actually, again, I think the healthcare system doesn't exactly know how to invest and make communities better places until you meet someone like Maurice who can actually make that happen, and all of you out here. So Maurice, we heard a little bit about from Kate in terms of the development of the institute, the Social Determinants of Health Institute. So tell me a little bit. I met you right when you took over LISC. Tell me about your sort of evolution when it comes to health being related to your work for LISC, but also more broadly for the community development sector.
Yeah, I think, I think for us, one of the crystallizing moments was when we were in the process of comparing the characteristics of the places where we work. We work in primarily the disinvested places in urban and rural America versus those places within the same metropolitan area, but were not disinvested. And there were a number of data points, right? You got higher poverty, right? You got much higher unemployment. You got families working at 60% of area median income. But one that really jumped out for us was the difference in life expectancies. And I mean, it was startling. I used to work in the state capitol in Richmond, Virginia, when I was in state government. And literally, I could drive 5 minutes to the east of the state capitol, and the life expectancy in those census tracts was somewhere around 69 years. And I could drive 5 miles to the west of the capitol, and the life expectancy in those census tracts was somewhere around 83.
Right.
And it had nothing to do, by the way, with access to care. These are babies that were being born in the same hospitals, but growing up 10 minutes away from one another. And because of primarily the conditions of poverty and the conditions of stress in the schools, those social determinants, that's what was the primary influence. Access to food, that was the primary influence on the difference in life expectancies. And so that really for us was one of those moments where we stepped back and said, we need to find partners to work on this, because this is part and parcel of what we have to be able to conquer as we're trying to help people transform and people to transform communities. Well, where should we find those partners? The healthcare industry, right? They are seeing these patients in their emergency rooms. They know more about them, frankly, than we do. And so we went looking for partners. First, we committed money, and then we went looking for partners, and ProMedica was already there. And so ProMedica was the first partner who we had already been working with, who signed up with us to say, yep, we want to go big with you on this. And so that's really, for us, that was what catalyzed it, but it really was an accumulation over the body of work to see that, wow, healthcare really is the big partner that we need to be working with.
Yeah, and you guys saw some of the maps. Carol had put some of them up. The data is now available. In fact, our website, buildhealthyplaces.org, has mapping tools that can help you actually show life expectancy in your communities and nearby, and you can hear how profound that is. And tell everybody what was your announcement? I think it was almost a year ago.
Yeah, we committed, over a year ago to spend $1 billion in the next 10 years intentionally trying to move metrics related to health. And the big spot on the wall is this life expectancy gap.
Right.
And literally within months, we announced a $45 million fund for social determinants of health in Toledo with ProMedica.
Yeah, so this was a big deal. You have a large community development organization making an announcement about changing life expectancy in low-income neighborhoods. It's pretty impressive.
By the way, all of my lawyers told me never to do that.
I know, right?
Ours too.
Yeah, exactly.
So this is when you don't follow your counsel. Now, we'll see who has the last laugh, right?
So Kate, something we talked about on the phone was that there's more to measuring impact in this kind of work than just ROI, return on investment, or health impact, but there's a moral component to that. And so, you work for a healthcare system that is in fact worried about the bottom line. So how do you balance the moral component of this work with the sort of need to actually help it pay for itself?
Yeah, that's a great question. So I think we've got to make the case both ways. So certainly there's a business case to be made around investing in communities that you serve. And so I think some of our early data is actually indicating we can not only improve health outcomes, but actually reduce healthcare cost when we think differently. So certainly the business case is there. Our CFOs at a health system, lots of our finance team and board members, you've got to make that case. But the reality at the end of the day, we're a nonprofit hospital system. And so we don't pay taxes. There are about 3,000 nonprofit hospital systems around the country. And because we don't pay taxes, we essentially have to prove what our benefit is back to local communities. And if we have huge buildings, we invest millions of dollars in capital, and yet the communities that we serve aren't healthier, if we don't see childhood infant mortality rates, if we don't see obesity rates, if we don't see diabetes rates across our entire communities, I think for us, we fundamentally had to ask ourselves, why are we here? What's our purpose? What's our mission? And again, hospital clinical excellence is incredibly important. That's still our core business. 20% of individuals' health is driven by whether they get quality care or not, but that's only 20%, right? The other 80 are all these community issues, community development issues, housing, job creation, transportation. And so for us, it was really about embracing this idea of an anchor institution. So we're based in Toledo, Ohio. We will never move. We certainly will expand, but we are based in Toledo, Ohio. We have a $7 billion balance sheet. We have 70,000 employees. We have huge contracts, everything from 70,000 employees.
Wow.
So everything from landscaping to cleaning facilities. And so the question that both our CEO and our board came to was to say, all right, we've got all these assets, all these resources, and yet if we're only focused on building buildings and the health of the communities we are serving aren't getting better, then why are we really here? And so this idea of an anchor institution, being focused on anchor mission, and really concerned about the broader health of our community is core to who we are. I would argue it's core to how all nonprofit hospitals should be thinking. Mm-hmm. And so in addition to the business case, certainly the moral imperative to invest in both the patients and the employees that we serve as well.
Mm-hmm. So this is not a question we discussed, but I'm curious, was this transition, so obviously everyone here has hospitals that are nearby, sometimes even in the neighborhoods they're working in, was this transition driven by the CEO, by the board? Why, really the question is, why aren't all nonprofit hospitals doing the kind of work you're doing?
Yeah, so I think there was two big factors. Obviously, we have an incredible CEO, so I give incredible kudos. He jokes that every day his job is to create urgency, and we say, okay, Randy, we got it, got urgency. But when you look at healthcare, and I mentioned at the beginning, of all the developed countries, the United States spends the most on healthcare, and yet we have the poorest outcomes. And we're starting to see huge disruption in healthcare. So whether it's Amazon and Berkshire Hathaway, you're seeing huge mergers between insurance and folks like CVS. And so the way that healthcare will both be delivered and paid for probably in the next 5 to 10 years is really going to fundamentally change. It's not going to look the same way. And so the buy-in to say, hey, we want to be on the front edge of this. We want to lean into this. We want to think about how do we ask different questions? How do we invest differently? How do we care not only when an individual or a patient shows up into our emergency room, but how are we making sure that that person has stable, affordable housing in the first place? And so this transition in thinking about how do we invest, how do we deliver care outside our four walls, I think is really something that we're starting to see healthcare embrace. It's still probably a little bit of a bell-shaped curve, right? So you have some folks that are cutting edge. There's probably 10 to 12 hospital systems around the country that are leaning in heavy. They're investing in CDFIs. You probably have a very small handful that will probably never buy in. But in general, I think the healthcare industry is really understanding that the social and economic factors drive health, and that we've got to be thinking differently. It's things that you guys have been doing for decades. Healthcare is just now understanding that there's a connection between housing and health, or jobs and health.
Yeah.
Kate's being modest. The bottom line is, there's no question that our hope is that all healthcare enterprises will embrace the anchor institution status that they have, whether they embrace it or not. But I'll give you an example. We knew that it became abundantly clear very early that Kate and Randy Elstra, the CEO, were driving that hospital, to embrace that mission, even before. The gradualism or incrementalism was not what they wanted to do. And I'll give you an example. We have this strategy of preparing people for work we call financial opportunity centers, where you can come into a center, and if you're a resident of a low and moderate income community, you can get financial literacy training, you can get help with accessing benefits that you're eligible for, and you can get workforce hard and soft skills to get you prepared for a living wage job and or career. We try to find local organizations to invest in them, usually CDCs or community colleges or something of that nature, so they can become the Financial Opportunity Center. Well, in the case of ProMedica, they decided to become the Financial Opportunity Center themselves. No other hospital in the country is doing that right now. We finance the construction of supermarkets in food deserts because food is a big issue. Usually our biggest issue is finding an operator who can make a go of it. Guess who the operator is in Toledo? The hospital. Wow. Right? So I wish every hospital were as aggressive as they are. This is where leadership comes into play. And so Kate won't say it, but I'll say it. The fact of the matter is Kate and Randy Ostra are embracing this anchor institution status like no other hospital I've seen anywhere. And my invitation to other hospitals is, if you want to know how it's done, look in Toledo. That's how you be aggressive.
So Maurice won't say this, but I'll say it too. So we certainly have the desire and the philosophical mission. LISC as a partner really accelerated that work for us, right? So at the end of the day, we're still a group of hospitals, we're still providers, we have an insurance arm, but their expertise, their knowledge in taking evidence-based programming, implementing it, tracking data, certainly accelerated the work. And so the partnership, again, really unique, huge opportunity, I think, to scale that nationally, but we got there quicker thanks to LISC.
Right, because you both brought different expertise and skills. You actually started to answer my next question, Maurice, which is, how big could this be? How important is this to LISC? How important is this to this type of work, this healthcare thing?
I'll give you my sense. LISC celebrates 40 years in existence. And in that 40 years, we've invested about $60 billion with partners. And our anchor institution partners for the first 40 years has been the financial industry. It's been CRA-motivated banks. I believe that the anchor institution for this work going forward is the healthcare sector. We are more aligned when it comes to mission with healthcare than we are, frankly, with the financial institutions who, but for CRA, and I know they're going to kill me for saying it, but for CRA would not be with us nearly like they are now. But here, there's a marriage of mission, and there is a commitment to place. There's a commitment to people. I think this is the biggest new partnership for the field that exists. And the question is how well we get it done. How well we get it done. But we're talking about billions of dollars of investments in the communities that we all care about. And hopefully we're talking about improved health outcomes and improved mobility for the folks that we care about.
That's great. You heard it here first. One thing just to, because the numbers can be really overwhelming, to me at least, so just to give you a little sense of the scale, because I think you're right, Maurice, is we spend $3.5 trillion a year on medical care in this country. 1%, put in your head, can you think of what 1% of $3.5 trillion is? It's $35 billion is 1%. Like that's not even, the healthcare system doesn't even notice that. And yet we're talking about the scale. And so it really, there's the potential there through efficiency and through healthcare savings and creating greater opportunity for families that's really possible. And actually that leads, Kate, to the question I have for you, which is related to that is, as I mentioned earlier, it's not just about ROI, it's not just about healthcare cost savings, but you do need to measure that, but you're also trying to measure other things. And so given some of the other, I didn't even realize some of the other interactions you have around the job training center or the grocery store. How are you guys measuring success? How are you going to know you're having the impact you're hoping to have?
Yeah, that's a great question. So I think one of the things in the connection between health and comprehensive community development is the ability to share data. And so you think about data around housing or jobs, which is incredible, it's making the case, but when you start to pair that with someone's overall healthcare cost, or a reduction in utilization rates, or a reduction in an individual coming into the emergency room again if we didn't treat them the first time. And there's real dollars on the line for those things. And so when we start to look at not only does an individual spend 30% or less on their housing, but what's the impact if we can get that individual into stable housing relative to their healthcare cost? A quick example that was really an aha for us, we had a patient recently that was actually diagnosed with prostate cancer. So he came into our facility, he was screened around food insecurity, so we asked all of our patients across 10 domains. He screened positive that he was food insecure, and so we asked a couple more questions. He actually landed at the Financial Opportunity Center that Maurice referenced earlier. We actually found out that this individual was living in a shelter 2 blocks away from our grocery store. And through the Financial Opportunity Center, we were actually able to connect him to housing. So today he's in his own house, he's established a bank account. If we didn't ask questions, if we didn't think differently, and if we didn't partner with a community development organization, we would have never been able to solve for that. And so certainly there's incredible value in that individual moving from being homeless to housed, and there's lots of data around that. But what we're also now looking at is what's the healthcare cost? Did that reduce? And it did. We're actually finding that it hit that individual, in addition to that entire sample of folks that are using the Financial Opportunity Center, actually showing improved health outcomes and reduced costs. So it's still really early on, but the early data is showing that there is incredible ROI, and to the case where we're starting to talk to payers to say, all right, if we're going to provide food or housing, that the payer, either both government or commercial payers, should actually reimburse things like food or reimburse housing, which is really what we believe is the next frontier for healthcare.
And this is a potentially slightly uncomfortable question, but one issue that comes up with healthcare systems, hospitals, is what they call heads in beds, or what has been called heads in beds. By definition, the way we run a lot of healthcare in the country is you need to have your beds full. In fact, when I was a resident in training, there was a census board as I walked in the door, and it said how many beds were empty, what the percentage of beds were that were full, and we were supposed to keep them as full as possible. Now, of course, ideally, you keep them filled with insured people who are there briefly and get out so someone else can come in. But what's the balance? Now, it's interesting that you have an insurance company as part of your sort of larger organization as well. Does that play a critical role, or how are you balancing the fact that you're making people healthier? They're presumably not coming to the emergency room, which is, in this current state and age, loss of income.
Yeah, and this is a real tension and something that even internally our team struggles with. But the reality is that the disruption in healthcare is coming. Right? We're not going to be the same the way that we deliver care in the next 10 years. The number of hospitals that we have in this country, we overbuilt the Burt-Hilton Act, and so fundamentally the way that we deliver care is already changing. And so we're moving from a volume, that beds and heads, to really value-based care. And so you're starting to see both insurance companies, but also Medicaid and Medicare start to say, all right, we're going to pay for value. So it's not just to treat someone and get them out the door and churn and burn, but we're going to really start to move to value. And so you're starting to see things like Affordable Care Acts, say the ACOs. You're starting to see risk-based contracts. And so I think for us, and what we're seeing around the industry, is that the disruption is happening. If we only stay focused on the number of beds and the patients that are full, we're going to be fundamentally, we're going to be out of business. And so that disruption in thinking differently, again, about how we deliver care and how we pay for it is incredibly important. It's coming whether we want it or not. The one other thing I would just mention around the dollars. So for nonprofit hospital systems, I mentioned this community benefit. So we have to basically pay back what we should pay in taxes or we don't have to pay. And my hospital friends probably won't love that I say this, but we're not incredibly strategic about how we spend those dollars.
Right.
So typically, someone comes to a CEO or a board member and says, hey, I have this project, I have this program, will you fund it? And so there's millions of dollars in each nonprofit hospital system that's going out the door, and it's not necessarily evidence-based, it's not necessarily tracked, it's not done strategically. And so you think about the ability to harness those community benefit dollars to drive to things that we know make a difference, that can show change in place-based strategies and things like housing, just incredible opportunity. And I would agree with Maurice that healthcare, I believe, also is really the next frontier in this work and the next partner.
Mm-hmm. Yeah, so there are two takeaways in there I think are invaluable for this audience. One is that if you were to speak, for example, to one of the healthcare systems in your community or in your neighborhood or in your city, they may not respond positively right away with the idea, especially if they're still thinking about heads and beds. But to Kate's point, it's coming whether they like it or not, and you're all well positioned to help them with that problem. The second thing is around the community benefit. They have to declare community benefit every year, and you can help them do it more effectively, especially if some of those community benefit dollars are aligned with some of the other investments that you're already making in the neighborhoods they're working in. Because you're all working in the exact neighborhoods that are creating a lot of the churn, the emergency room overutilization, the unreimbursed care potentially, depending on what state you're in. So you can help solve problems that the healthcare system has, and I think that puts you in a better setting for those conversations. So I've got one last question for the two of you. So Maurice, so we've got here 20 as of yesterday, or this morning, I guess, 20 purpose-built community network members, and another 40 or so, 40, even 50 communities that are potentially considering that here. What can you say to all of them about sort of the relationship you guys developed, or how might you advise them to think about moving forward from their perspective on these types of partnerships?
You know, and you all already know this, but it's a contact sport. You have to build relationships, and you have to do everything you can to try to understand what the hospital needs in order for a partnership like this to actually be viable and sustainable. And we have to be flexible in the value proposition that we're putting forth to work with them on. But look, purpose-built is about education, it's about health, it's about housing, the alignment with the issues that healthcare is wrestling with. The first partnership we did with ProMedica, just to give you an example, was ProMedica was seeing an increased incidence of asthma in youth coming from a certain neighborhood, right? And what we did was we partnered with them. We created a little fund with ProMedica and a bank to provide grants to homeowners in a particular neighborhood to upgrade the health quality of their housing, right? So the overlap in the problems that we're trying to solve are great. But like I know, not everybody is going to be as aggressive as Kate and Randy. Most are trying to find their way. Most have no clue about community development. And most will need a lot of relationship building to get there. But they will get there, and they can get there. And we just have to invest in the relationship time that it takes to find our way to yes. Because it's critical at the end of the day for the people that we're trying to serve.
Great. I mean, it really sounds like having that initial conversation, what are the shared goals, and thinking about what both sides can bring. So Kate, what's the future for ProMedica in this work? You're expanding dramatically, either about to or just did. Right now you're in Northwest Ohio, Southeast Michigan, but what's next, and what's next in terms of social determinants of health?
Yeah, so we recently acquired a company called HCR Manor Care. So they're in the long-term and senior care business. So it puts us in about 30 states around the country, about the 15th largest healthcare
So from 2
system.
to 30.
Yeah, which is both exciting and terrifying, right? So we're excited. I think we're thinking a lot about how do we develop relationships across that expanded footprint. But I do think you're going to start to see more healthcare jump into this space. And again, it's both the business imperative, but also the moral imperative. We also founded the Root Cause Coalition, and so we did that in partnership with the AARP Foundation. It's a multi-sector coalition really focused on the social determinants of health. Healthcare is there, but there's also business and government. And so it's really an opportunity for folks to convene and ultimately advocate at the federal level around policy change. So as we think about what healthcare will look like in the next decade, how does that get funded? What are the deliverables that we're required to do as patients come in our doors? And so I think, across healthcare, it is going to be this huge disruption. And the folks that lean into this, the healthcare providers that embrace what they can do to improve the communities are going to be the ones that are probably still surviving at the end of the day.
Can I just add this? The other thing I should say is for those of us in the purpose-built community and in the community development arena, we got to be aggressive, right? So Kate just mentioned the Root Cause Coalition. So we joined.
Right.
So you got to go where hospitals are. You got to go where healthcare, insurance come. Find where they gather and go. In fact, before we became a member, I went down to the first meeting of the Root Cause Coalition. I got lucky enough to get on the panel, but what I really did was I sat outside the doors of the meeting rooms waiting for people to come out and said, "Hey, have you heard of LISC?" And they were like, "Nope, don't care about it either," right? But you got to get a lot of no's to get to the big yes, right? But be aggressive in pursuing healthcare as a partner. That's the way that I'll tell you it has worked for us, and we're going to be announcing some other partnerships. But we're getting a lot of interest. The real question, really, that we are having to grapple with is how. It's the how they actually get the work done with us, because this is not something that most of the hospital systems are used to.
How many members are in Root Cause Coalition now? Do you know off the top of your head?
Yeah, almost 60 folks.
Yeah,
so a lot of healthcare providers, a lot of payers, some of the big national payers as well.
Yeah, so it's worth looking at your own community again, with those hospitals, see if one of them happens to be that suggests they're going to be more open to a conversation with you, and if they're not, ask them why they're not, or put them in touch, because it is a growing, and I love the name, and Root Cause Coalition, like let's get to the root of the problem and really solve that.
By the way, they get jealous of competition, so if you tell them about the great things ProMedica is doing, that might create a little competition as well.
Exactly. Well, good. We have a few minutes for questions from the audience for our speakers, and then I think we're going to wrap up a little before 2 o'clock and have a break before the next session. So there's at least one microphone. Yeah, there's 2 microphones. So people have, actually, I don't know if there's a mic on that one there. Oh, there they are. Yeah, far left and far right. Anybody have any questions for Kate or Maurice about?
There's a gentleman over here.
Oh yeah, please go ahead.
Thanks, if you could hear me. I'm actually from a health plan.
So
great. I appreciate the focus here. I don't think we have a president of social determinants of health in all of Northwest America, so it's good to hear this. I was surprised to hear, the reference to the Community Reinvestment Act on the financial side, and then saying the future could be with the healthcare side as a replacement. I guess the question I have, I appreciated the candor about that nonprofit hospitals and other nonprofit healthcare providers don't pay property taxes or insurance taxes, and therefore there's an incentive. But I have been a little struck, and actually it's been refreshing to not hear much about the role of the federal government in this conference. But when it comes to the issue of wouldn't it be helpful to have some regulations that encourage community reinvestment in the healthcare sector, so we don't rely just on the good graces of the good actors like
So-
we have in the Community Reinvestment Act, I would think.
Yeah.
What's your reaction to
So
that?
my reaction is I would love that. And in fact, I've said to folks a lot that, look, I'm looking for the analogy for healthcare of the CRA for banks. And by the way, I think banks will continue to be with us, that healthcare will be additional anchor institutions for the work. So yeah, I don't know what it is yet, but I would love to see an incentive to help hospitals do more of this kind of work. But as I also said earlier, I also believe that from a mission standpoint, the alignment is much stronger with healthcare than it is with financial institutions. And so I think you do have the benefit of having a marriage of missions here that's pretty doggone strong. But to the extent that we could come up with incentives at the federal and state and local level, yeah, I think that would be helpful as well.
I think you're also going to see, and we're starting to see some of that early data I mentioned. So if we can prove that investments in housing or food has a strong ROI related to cost, and you're starting to see some of that. So for example, when individuals screen positive for food insecurity and we get them, we actually write a script for food. And after 12 months of that, we actually show a 15% reduction in per member per month cost, which for health insurers and health plans, that's the holy grail, right? So if we can lower that per member per month cost, that's huge. And so as we're starting to get that data, to share data to think about housing or food or job creation and how that impacts healthcare cost, in addition to the help around the federal government, you're also just seeing payers and providers also start to both embrace this and also pay for this as well.
And the community benefit requirements are requirements for the hospitals, but there's not a hard amount you have to demonstrate you've provided to the community, and it's not terribly aligned in terms of the incentives to do it. And so there could be a lot more work to make that clear. I'll add too, I don't want to leave the impression that the only role of hospitals is the community benefit dollars either. Because what's really fascinating is the investment portfolios that the hospital systems, large insurers, large healthcare systems have hundreds of millions, in some cases billions of dollars of investments because they're large institutions. There's a large Catholic healthcare system on the West Coast that has only 2% of their portfolio is available in a loan investment or loan pool for investment in low-income communities. It's $140 million. That's 2% of their entire investment. Again, if every healthcare system put 2, 3, 4, 5%, they get a return on that too. These are not gifts. This is just a low rate of return. So you can really start to have an impact. Next question.
Hi, yes, thank you. Great panel, thank you so much. I'm really excited to hear about the partnership. I want to amplify what you were talking about community benefits, particularly under the Affordable Care Act. Can you all talk about your thinking of the role hospitals play or as an anchored institution around the built-in natural environment? If, for example, healthcare is supposed to get to healthy outcomes, then what is the responsibility of the hospitals to ensure that the neighborhood around it is healthy, that you can walk, that you can bike, that there's access to park systems? And then what about using some of those community benefit dollars to support those types of improvements in the neighborhoods surrounding the anchor institution?
Yeah, I appreciate your comment. I think that's exactly the point to this, is that those dollars are available. The way that we use them and deploy them could be stronger in partnership with folks like Purpose Built. So one of the things that we did about almost a year ago now, in partnership with the Ebeid family, we made a $50 million investment into one neighborhood in partnership with LISC. And that was very much social service delivery. So adding more community health workers, adding more financial coaches. And as we did that investment and started to peel back and say, okay, what are the programmatic elements? It became very apparent to us that the physical infrastructure of that neighborhood also needed support. And so you can have a lot of programming, but unless you were going to address vacant lots or dilapidated housing or support viable small businesses, that the neighborhood itself wasn't going to churn. And so the partnership with LISC around the $45 million impact investment was to actually support that that capital infrastructure of neighborhoods, which we're really excited about. The other thing I would just throw out, you are seeing a lot of hospitals invest in the neighborhoods that are adjacent or near their hospital campus. And while that's important, I think as we think about the investment that happens in neighborhoods, one of the challenges healthcare needs to be pushed is to think more broadly. And so our $50 million investment that we made was not adjacent to our hospital campus. It was adjacent to our downtown core business district. And so we've had a lot of activity happening in that business district. New businesses, we relocated about 1,000 employees as part of our anchor mission to the core business district. But the neighborhoods that surrounded downtown, the low income, majority minority neighborhoods had not seen that same level of investment. And so we strategically said, okay, how can we ripple some of that economic development, that movement from the core business district into those neighborhoods? And so we chose a neighborhood, again, that was not adjacent to our hospital campus, but that was really trying to spur and ripple the impact that Toledo as a whole we hope to have.
Mm-hmm.
Yeah, I think the promise in this area is great. One hospital that we work with is Dignity Health, based out in Oakland. And Dignity invested in a fund that we have used to develop affordable housing and also to develop supermarkets in food deserts. And we're in conversations now with a number of hospitals about using their anchor institution status to do housing and small business in the neighborhoods that surround the hospitals. So all of that to say that I think that is a part of the promise of these partnerships.
Mm-hmm. I will not take, I just want to say yes to everything you're saying. However, still the physical environment, if it doesn't support a more kind of walkable, vibrant place, it's still just going to fall flat.
I'm with you.
So we can help you.
I'm with you.
Yeah, and I'll add, one of my jobs actually at the Build Healthy Places Network is to tell the stories of where this is happening well so that other communities don't have to recreate the wheel. They can learn from what ProMedic has done, for example. And so we are gathering stories and making them available. So we just have a couple minutes, so let's actually just do both questions. So just ask us your question here, and then we'll switch over and hear your question. We'll try to answer them both together.
So thank you very much. My name is Angela, and I want to thank Maurice for representing Norfolk, Virginia well. My question is, in all of the work that you're doing with regarding helping the lower to moderate income communities, is there any talk or conversation or efforts in place to help those children who may be interested in the medical profession to get, through the third grade reading level, obviously, but through high school and college and into the medical field, so maybe they can come back. They're more than likely minorities, and so they can come back to those communities and help the same individuals that are in the position that they were once in.
That's great. So a pipeline question around kids and training. And last question, and we'll answer both.
And actually, what she said. It was the pipeline question. My name is Blaine. I'm a councilman in the city of Cleveland, where Cleveland Clinic exists, and we have an opportunity to do the same thing. She couldn't have said that question more articulately. The only thing that I will add to that is how do you deal with your existing employees with providing incentives like we provide Greater Circle Living dollars through the Cleveland Foundation and other institutions in order to make sure that we try to encourage some of your employees to live in the communities that they're actually served. So interested in what she said and also to add what I just asked. Thank you.
Great. So living nearby and the pipeline.
Yeah, so I think great opportunity. One of the realization or aha moments that we had, we thought about how we could serve our communities and then our patients, and yet the reality is that a lot of our employees are living in the same neighborhoods that we are trying to work in. And so that engagement, not only on helping our employees that might move into neighborhoods, but we have employees that are currently living in those neighborhoods. And so how is it that as a healthcare provider and also as an employer, how do we think about that interaction and that support? We're actually partnering with LISC to build out the Financial Opportunity Center around the Bridging Career Opportunities, or BCO model. And so that's really focused on employment. For us and around the country, nursing is one of the professions where there's tremendous need. So pretty much every hospital system around the country really struggles to fill nursing. And so that's both from the entry-level positions, nursing assistants, all the way up into masters and very experienced nurses. And so we're actually partnering with LISC to do that and to not only attract individuals that are in the neighborhoods we serve, but again, we have a lot of folks that might be in either environmental positions or dietary. They're current employees working for us. And so how is it that we can provide opportunities for them, if interested, to enter the clinical field and provide not only a job, but also those wraparound services that we know often are really important. And so certainly as an employer, we can provide a job. We've made a commitment at a living wage, so all of our employees are at living wages. But if they don't have transportation, or if there's financial challenges or childcare challenges, the job in of itself isn't enough. And so how do we think about those wraparound services? The Financial Opportunity Center and then the Bridging Career Opportunities is the model that we're working on to support those employees.
I would just add to that one of the biggest opportunities for partnering with healthcare to particularly focus on youth is with the children's hospitals that are out there. So in Hampton Roads, CHKD should certainly be an opportunity to do this work. But in the hospitals that we're talking with that are children's hospitals, that's where they want us to focus. They want us to focus on helping them to do good things for children, including career pathways into healthcare. And then we are working with employers, though none in the healthcare space right now, who want to establish financial opportunity centers for their employees. They recognize that they have a huge swath of employees who, on a day-to-day basis, are wrestling with a lot of issues. And what we try to do is try to be a influence for making sure that they're paying the employees livable wages, while also trying to bring this strategy of talent development to the table for their employees as well. So lots of opportunity is the bottom line.
Great. So I want to thank our speakers. Thank Kate and Maurice.
Thank you, Kate.
I want to thank all of you for the great questions and the attention. I just checked the schedule, so we have half an hour till 2:30 when we're actually going to take a similar theme but zero in on Orlando, because it turns out one of your own sites, the Lift Orlando site, is one of the most extraordinary examples of healthcare and the insurer getting directly involved jointly locally. And so it's a come back for that at 2:30, but I believe we're free till then. So thank you all very much.
Great. Thank you all.